This is like a sandwich. This session's like a sandwich. You're going to have two technology talks, and I guess maybe I'm the hamburger meat in between the bun here. I'm going to be talking about policy and both aspects are very important for testing. And this talk is barmaid certified. I know that because I married my barmaid when I was a resident. So it has that seal of approval. So let's talk a little bit about birth cohort testing as an example of broad-based HCV testing. In the United States, CDC recommended a one-time test for HCV for all persons born between 1945 through 1965. We went through an evidence-based process. That evidence included a recognition that between 45 to 60% of people were unaware of their infectious status, reflecting the limitations of risk-based strategies which had been in place since 1998. This recommendation was seconded by the U.S. Preventive Services Task Force, which went through its own evidence-based process. Both of those efforts had a public comment phase, and both of those were brought together with pre-existing risk-based strategies as well as medical indications for treatment. And what the USPSTF recommendation was very important in providing was requiring HCV testing to be offered to patients in health plans as a no copay clinical preventive service, so they did not have to pay out-of-pocket expenses, which previously had been a barrier to testing. Now, we look at birth cohort testing as really a prime strategy to help CDC in the U.S. respond to two epidemics of HCV. We have an epidemic of HCV transmission going on among young people related to injection drug use. We've had about a 150% increase over the last several years. It's about a male-female equal distribution, and it's really impacting suburban and rural parts of the country. The other epidemic we're having is morbidity and mortality, and that's heavily focused in this older group of persons who are living with hepatitis C, who were infected decades ago, many before the virus was discovered in 1989, and now they're progressing through time and progressively increased risk for severe HCV-related liver disease and mortality, as represented by those proportions in the slide there. Now, just to give you some examples, this is a very recent example. We are participating in the development of what's called the Annual Report to the Nation on cancer, and liver cancer is being highlighted in this particular issue. It comes out every year. So we did an analysis looking at trends in HCV-related liver cancer, and as you can see there in the light blue line representing the birth cohort, it's had the largest increase in HCV-related liver cancer by birth cohort category and now has a much higher rate of liver cancer than other birth cohorts, just to give you one example of the increasing morbidity for this population. And this is contributing to an increase in HCV mortality. Now, we published in 2012 that in 2007, the number of deaths from HCV in the United States surpassed the number of deaths from HIV. So we extended that analysis over the last several years, and this was led by Dr. Scott Holmberg and our group, where we then looked at other diseases that are required to be reported to CDC, the so-called nationally notifiable diseases. And indeed, when you looked at those, we didn't look at any, we found that if you looked at all the deaths from all of those over 60 diseases that are required to be reported to CDC, the number of deaths from HCV surpassed all of those deaths collectively. Just to give you some sense of the epidemic of morbidity and mortality that is evident in this epidemiologic data. There's been a variety of cost-effectiveness models that have shown birth cohort testing to be cost-effective, and this is just one that was led by Dr. David Ryan, who's here at this meeting and will be speaking tomorrow, where we showed that birth cohort testing was, with the currently recommended all oral agents, was very cost-effective, between $32,000 and $35,000 per quality-adjusted life year, and that even with modest expansion of the capacity to test and link to care those individuals, you could save over 320,000 deaths over the course of their expected lifetime. So a big impact. Rising morbidity and mortality, opportunity for big impact. So let's see how's it going. When we put out this recommendation, we got some money, a time-limited money, 2 years' worth of money from the Congress to evaluate different strategies for HCV testing. And we put that out to a variety of investigators at a number of cities that are listed here. That resulted in testing of over 29,000 individuals, finding an average prevalence of anti-HCV of 10%. Of those who were tested for HCV RNA, 70% had evidence of current HCV infection, and then we were interested to see if they could be referred for care. And as you can see there, the referral to care was quite good, and over 2/3 of those attended that first appointment, which was the end point of that demonstration project, or that group, or this group of demonstration projects. Let me give you a couple of examples of the strategies that have shown themselves to be effective. One is in a study that was done in the emergency department in Birmingham, Alabama, at the University of Alabama in Birmingham, where they implemented a standard process whereby when people in the birth cohort checked in for care, the intake clerk let them know that it was standard practice in the emergency department for people in the birth cohort to be tested, and then for that test to be automatically ordered. Now, only about 13% refused that testing. They opted out of testing, and then the remainder were tested. And then they had some patient educator on staff so they could help provide counseling. In this study, which was published in March in Hepatology, they found about 11.1% of those persons were anti-HCV positive. RNA testing was very good. We find that overall in the United States, we have a big gap between antibody testing and that individual is positive. Only about half of those persons receive RNA testing. So the RNA testing is good. 68% evidence of current infection. Only 54% were referred for care, and then a smaller proportion actually attended that appointment. But let me point out that before they did this study, this ED was completely unaware that they had this high a prevalence. And if you don't test, you don't find, and they find, and now they're going into a second step of improving that linkage to care. So standing order and integrating testing into ongoing clinical care. Secondly, in a study led by Dr. Barbara Turner at the University of Texas in San Antonio that was published this past summer, they implemented routine birth cohort testing in what's called a safety net hospital, serving a predominantly Hispanic patient population. Again, they had a standing order whereby persons were automatically tested when they were admitted to the hospital unless they chose to opt out, and only 10% of individuals did so. So they had a standing order. And then they had a care coordinator for those found positive to help them be referred for care. In this study, they found that about 6.9% have evidence of anti-HCV, 91% had RNA testing, 61% were RNA positive, 85% had their stage of liver disease evaluated by serologic algorithms or by imaging, and 34% had evidence of severe fibrosis or cirrhosis. And these are individuals who were previously unaware that they were HCV infected. And they had a much smaller number that had received treatment as of this past June. So again, standing order, care coordination. So those are demonstration projects that we funded, showing that if you have a program, you can have some success. But we want what's going on nationally, what's going on in the whole country. And you have to, in that context, you have to think, what's your capacity for implementing this intervention? CDC spends hundreds of millions of dollars implementing HIV testing, breast cancer screening, colonoscopy screening. We actually try to affect, we have only several $million to do this same type of activity of trying to integrate a new clinical preventive service as part of routine care. So we have been assembling laboratory data to see what is really going on out around the country. And so we've developed relationships with large commercial laboratories. One is known as Quest, which their data is represented here. The other is LabCorp. And we've just began to look at this over the last several months to see what is the trends in testing and how does that relate to the launch of this recommendation. And we found that, as you can see there by the top line, that the testing of persons born between 1945 through 1965 in the Quest system has risen following the release of these guidelines by CDC and by the U.S. Preventive Services Task Force. Another data set we've been looking at is what's called MarketScan, which is a system that brings together clinical data and pharmacy data for millions of patients around the country. So we looked at, and we just looked at this last week, so I'm really giving you some real hot bread here. Just looking at the 10 years of MarketScan data. And what is very interesting, I believe, here, so we looked at trends for 05, 09, and for 2013, showing that over that time, HCV testing for the birth cohort, the reasons for that testing changed from liver-related, i.e. looking for a diagnosis of a liver problem, to general physical exams, suggesting that they are indeed beginning to be screened rather than being worked up because they already have evidence of liver disease. So that's some other indirect evidence, granted, that this guideline is being implemented. So is birth cohort-based testing delivering on the promise? The policy is temporally associated with increased HCV testing, albeit with very modest implementation capacity. In most United States settings, the birth cohort testing reveals populations that have a high prevalence. Feasible strategies have been identified that can spur and stimulate implementation: standing orders, electronic prompts, patient navigation, reflex testing for PCR following antibody is another. And that said, it's not the one-off testing strategy. This is not the only thing you should be doing, but it does look like it has a big impact. So is it delivering on the promise? Yes, with an emphasis on the promise, because we need a bigger capacity to really fulfill the potential that the birth cohort option can provide. That said, I think it leads to another question where, this conference is really all about eradication and elimination. And, I think the question that we need to pose to ourselves is HCV elimination possible without broadly based HCV testing, of which birth cohort testing in the United States is just one example of. For example, to take this a step further, I mentioned the other epidemic of HCV transmission. Do we want to rely on risk-based testing alone for this? Again, we're looking at, this is commercial laboratory data for persons born after 1965. I apologize for the legend on the left, but it's showing ranges between less than 0.5% to 2 to 2.9% for the darkest colors in the states, showing the prevalence of HCV among people in that age group being tested in, again, this is in the Quest system. 2011, now let's look at 2015. The prevalence is much higher. And that legend has also changed, and so the darker color is now greater than 3%. And you're seeing very high rates in states like Kentucky, West Virginia, Pennsylvania, Ohio, et cetera. Now, maybe this is a sign risk-based testing is working, so that would be great. But it'd be nice to know what was the stimulus for that testing and who's not being tested and not being found. But this is really suggestive. It's only reinforcing epi-data from other sources that we have a major problem on our hands among younger populations that not in the birth cohort. And the question is, do we need a broad-based strategy for that like we have for the birth cohort. As a case in point, in Kentucky, a state I pointed out as having a high prevalence, on their own, just in December of 13, they began just to ask obstetricians to forward reports of HCV positivity by pregnant women. And then about 6 months ago, they began to require that. And as you can see there, Kentucky is not a heavily populated state. It's mostly a rural state. Just in about 18 months, they had over 600 HCV antibody-positive pregnant women reported to them. So again, thinking broadly, is pregnant women testing another strategy to be identifying this younger population who have hepatitis C. And this has implications, obviously, for the rest of the world. I mean, most, as was mentioned in the first session, the great majority of people living with hepatitis C are unaware of it, except for a few notable leaders in the class, such as Australia. But otherwise, it's a pretty dismal situation out there. And if you're not testing, you're not treating. So how are we going to solve this problem? Is it by risk-based testing alone, or are we going to go big and get these people identified more quickly? You know, as a case in point, we've done some modeling. Greg Dorr and myself and others have been involved in this, at least writing some editorials about the work of Homi Razavi and Heinrich Wiedemeyer and others, estimating the burden of disease in various countries and pointing out that, you know, there's different birth cohorts in different countries have a large proportion of HCV-infected populations, and that could be one impetus or one basis for HCV testing. The birth cohort testing recommendation from the U.S., I'm happy to say, seems to have stimulated some thought in that direction in looking at the published literature where various countries have begun to examine their data in the context of identifying these birth cohorts at risk. So quickly, in the case of France, they have estimated that the population that represents the largest number unaware of their status are older persons in a 1924 to 1944 cohort. In Spain, just looking at laboratory data, they found about a 7.7% positivity with the highest prevalence in a 1955 to 1970 cohort. In Switzerland, looking at surveillance data, they found that 65% of those case reports were from persons born between 1955 and 1974. You know, both of those showing that it's important to base your testing on epidemiologic data and then tailor your testing policies accordingly. And then lastly, here in Canada, from Alberta, they looked at the feasibility of integrating HCV testing into the workup for colonoscopy, showing that about 90% of persons would agree to such testing, but they found a very low rate, about 0.8%. But it was of interest, those 3 persons that were found to have evidence of HCV infection were all in the 1945 to 1965 cohort, and they recommended more cost-effectiveness analysis. So it can spur some data, some more inquiry. So in summary, our testing strategies, the testing strategies are needed to meet our elimination goals. If we're going to talk about elimination, that's a big, big goal, and our testing policies need to be up to the task because it is a rate-limiting step for impact. And I believe our elimination goals should be focused on eliminating morbidity and mortality as well as stopping new infections. And to do that, we have to tailor our interventions based on the local epidemiology, the health system's characteristics, and the community acceptance of the policies being proposed. So thank you very much.